Hi, everybody. This is Don Sharp, and we're holding for just a minute or two. We're seeing a lot of people ready or jump in right now. We'll start in about one more minute. Hang in there. Okay, I think it's time we get started. Seeing a lot of people come in. We have over 600 people here, and so maybe a little bit of a traffic jam getting in. But I'm Don Sharp. I'm with OBR, and I'd like to welcome you to our sneak preview of ASCO 2021 webinar. Our best guess is that this is our 9th annual, but who's counting? The webinar today is brought to you by ZS Associates. ZS is a professional services firm that works side by side with companies to help develop and deliver products that drive customer value and company results. They leverage deep industry expertise, leading edge analytics, technology, and strategy to create solutions that work in the real world. And I can vouch for their expertise. The presentation and discussion you're going to see today was fueled by ZS expertise, probably about 99% of the content you're going to see. This is our second virtual ASCO. It starts June 4th. I, for one, am anxious to go back to Chicago. I miss walking the McCormick miles, and there's nothing like just missing your bus or waiting in long taxi lines. And believe it or not, I do look forward to that again one year. But we've all gotten used to this virtual format, and yet some things remain the same and some are different. We saw the pre-ASCO press conferences. The data drop was on May 19. There's been a flood of news and analysis after the abstract drop. And on the other hand, some things are different. And I don't know, I noticed that there are 48 live sessions, but there are 175 on-demand sessions throughout June 4 through 8, which feels to me like one of those pandemic permanent changes that is coming to stay, here to stay. From OBR, we're doing this preview webinar. We're doing coverage during and after the meeting. We've done a few previews already. Those are digging into particular tumor types and multimedia, but we'll also be producing coverage during and after insights and analysis. And then, of course, there's this webinar, which is intended to help navigate what can be an overwhelming amount of information when it starts flowing on June 4. So hopefully we'll be able to help you navigate it and identify some of the high potential clinical studies. But we're doing it a little bit differently this year. It's not just about the studies. We're putting the studies into themes or buckets. So I'll say that again. Themes, 3 themes that you're going to see that were presented by our panel. The panel has identified as important themes as part of this year's meeting. So to do that, I'm going to introduce the panel. Daniel, if you could, okay, there's the slide. And first up will be Sharon Carlsberg. She's a managing principal at ZS Associates. We go way back, and she's our only panel member on the West Coast. Sorry to get you up so early this morning, Sharon.
Happy to be here, Don.
Good. And our next 2 panel members, I feel like don't need an introduction. They are onco celebrities, or also because they're repeat members of this panel. So maybe you've seen them before participating in this webinar. But I feel like we better get on with the formalities with them anyway. So Dr. Deborah Patt will also be here today. She's an executive vice president at Texas Oncology. She recently added a new title to me anyway, as professor at the Dell Medical School at the University of Texas, Austin. Of course, those titles only tell a small portion of her story. She has many accomplishments in the field of cancer policy, community oncology policy, breast cancer, cancer informatics, and so on. Hi, Dr. Pat.
Thanks so much for having me this morning.
Good. And again, this year, repeat performance, Dr. Lee Schwartzberg. Dr. Schwartzberg is a senior medical director at the West Cancer Center and also identifies as the chief medical officer at Oncology, which is a group of oncology practices invests in and collaborates with each other to deliver comprehensive cancer care in communities. So Dr. Schwartzberg, thanks for joining us today.
Thanks for having me back, Don.
Good. And I think the point of those introductions is just to tell you, the audience, we have a subject matter expert, we have two practicing oncologists that are with us today. They're going to bring unique insights, and I think it'd be a shame if you didn't ask them some questions and interact with them and tap into their knowledge. Okay, so first, some housekeeping. We've got some great content, but there's a lot of it. I'm going to try to keep this at 1 hour. If history repeats itself, we will probably go over some. This is our first time doing this in Zoom webinar. We've got technical support available if you need it. But mostly, we want you to use your tray down there, has a Q&A button. You're muted. Don't try to raise your hand in the audience. But you can direct questions at the panel by using the Q&A box down there. And then I'll also add, because it's the #1 question, yes, the slides will be available. ZS is going to make the slides available to you. Put your email, affiliation, and name in the Q&A box. At the end, I hope you'll stick around for the end. We're going to do a little poll, live poll on what the most valuable part of this webinar is. And at that point, you can also submit your information to be able to, so we can deliver the slides to you. So stick around to the end. Okay, and then what I'm going to do now is I'm going to turn it over to Sharon Carlsberg, who's going to set the stage. She's going to give us a feel for the pace of change, we're calling it, in oncology before we get into the actual preview. And Daniel, if you could move the slide forward one, please. Sharon, it's all yours.
Thank you so much, Don. So it's a real pleasure to be here today, recognizing that oncology continues to be one of the fastest moving therapeutic categories. Every year, ASCO is a celebration of some of the best and brightest in terms of advancing clinical and even translational research. So one of the things I wanted to start by organizing and orienting us to the pace of change in terms of scientific innovation. What you're looking at is a slide that captures the number of ongoing clinical trials for more than 3,000 cancer drugs in global development. Two things may immediately jump out to you. First of all, the number of studies that are ongoing, as well as the diversity of studies within and across the various solid tumor and hematological malignancies. And so no matter what aspect of oncology you focus on, we can see that there's a tremendous amount of research, study, and innovation from some of the largest tumor areas like lung cancer and breast cancer, and continuing to see very active research in areas like melanoma, liver cancer, prostate cancer. And you'll hear about many of those exciting developments today. Next slide. As an example, one of the things I think all of us as panelists have been fortunate to witness is the amount of scientific innovation that has changed just in the checkpoint inhibitor class as one example. So if we reflect back over the last 10 years and think back to perhaps ASCO in 2011, seeing some of the very first data coming out on anti-CTLA-4 checkpoint inhibitors, right? The availability of Yervoy for the treatment of metastatic melanoma. And in the early 2010s, we saw a very rapid explosion in terms of the number of indications available for use for two of the anti-PD-1 drugs, Keytruda and Opdivo here. And we see that newer and more combinations became available with the combination of pembrolizumab and ipilimumab. We saw the introduction of additional anti-PD-1s and anti-PD-L1s with the availability of tezolizumab, durvalumab, evolumumab. We saw more options in some of these established mechanisms of action. And then we saw very rapidly the expansion across different tumor types. For example, if we look at the indications today for some of the anti-PD-1s, we see 18 different approved uses for pembrolizumab, 11 for your voice. So there's certainly a tremendous amount of expansion across tumor types. And even more recently, we've seen combinations with other drug classes, combinations of checkpoint inhibitors with anti-VEGF, combinations, of course, with chemotherapy in some frontline indications. And as we talk about not just the rise of innovation, but the rise of precision medicine, we've seen that in the checkpoint inhibitor class, the rise of tumor agnostic options, so that we can look at pathways, we can look at cellular and genetic expression that indicates the right treatment to use, rather than just focusing on a single disease area. And as we look ahead to the data coming out at this year's ASCO, we can celebrate, first and foremost, the long-term survival data we've seen with the checkpoint inhibitor and combination classes, upwards of 3, 5, and even 6 years in some disease areas like melanoma and non-small cell lung cancer, truly transforming care with the innovations in this category of immunotherapy. And today, we will highlight some of the novel mechanisms of action in development, looking ahead at new combinations across the immunotherapy class. Next slide. We see this, we've reflected to date on the innovation in terms of clinical development, the availability of new commercial combinations and new drugs and indications across the checkpoint inhibitor class. But really the innovation we see in the CPI category is reflective of a decade of innovation across oncology. And really we see the pace accelerating. If we look over the last 10 years of FDA oncology approvals, you'll notice two things. First of all, a rapid growth in the number of new indications and new molecular entities approved in the last 4 years. And second, you'll see the rise in terms of the proportion of those new oncology treatments that are available and paired with a companion diagnostic or a biomarker. This means that not only are we bringing new medicines to make available for patients, but we're better able to target the right medication for the right patient at the right time. And as we've seen, the rise of these approvals is very, very quick. Even on Friday, we can celebrate the approval of the first treatment for KRAS G12C targeted non-small cell lung cancer, a target that was considered undruggable for many decades, that now has a new therapy option for patients. So very exciting to reflect on the pace of change and the productivity of the oncology industry as a whole. Next slide.
And Sharon, I'll interrupt. You know, it's one thing to present and talk about it, but it's another thing to actually feel it firsthand, right? So Dr. Schwartzberg, Dr. Pat, any thoughts on this pace of change in oncology? How do you keep up?
Well, it's real difficult to keep up, Don, and particularly for community oncologists that are generalists. So using other tools, we're going to talk a little bit about digital tools, but within the practice, tools, NCCN guidelines, and other ways, resources that we can keep up. But it is a challenge. And I have to say, I've been doing this for many years, and that number of 2010 is probably still higher than it was in 2000 and in 1990. So it's so exciting to see this revolution in the number of drugs that are being approved as we understand the biology. And it's never been more exciting to be an oncologist. So it's fun to go to work every day because we have new tools to help our patients.
I would say more so, just building on what Lee said, is that cancer care is just an entirely different specialty than when I entered it 15 years ago. The use of targeted therapy and immunotherapy to render what would have been a potentially terminal or curable cancer now a chronic disease and increase our potential for cure has just really been revolutionary for so many patients' lives. And it does make our therapy choices and how we support patients living where they are really important.
Yeah, exactly. As Sharon said, I mean, it just changed on Friday already. I have to come in on Tuesday and figure out what this new drug is, right? Okay, Daniel, why don't you move forward? Sharon, could you please introduce, I talked in the intro about these themes that we want to discuss. Can you introduce those themes?
Of course. We are all very familiar with the volume of new information coming out at ASCO. And so what we thought, rather than try to cover every abstract, we want to highlight a few abstracts that really speak to some of the important practice-changing trends we are seeing at ASCO 2021 this year. Recognizing COVID and many of the significant changes, not just to where we are meeting this year for ASCO, we wanted to talk about how digital health and new digital tools have really helped to change, improve, in many ways, help us address some of the inequities we see in cancer care. Dr. Pat will lead off with that discussion. Of course, this year we see not just innovation in metastatic cancer, but we see a movement into earlier lines where with adjuvant and neoadjuvant therapies, we now have better and more potential for cure for long-term outcomes for patients. And finally, no ASCO would be complete without reflecting on some of the innovation that we see across modalities that improves even the research and groundbreaking work we've seen in different areas, such as combinations, immunotherapy, and cell and gene therapy. So Don, I look forward to you leading us through this discussion.
Yeah. So before I do that, just to get the Q&A going, remember you can put your questions in there. Maybe I'll ask you, Sharon, to speculate. One of the questions was, seeing this upward curve of new approvals, what do you expect for the next 5 years? Are we going to see a lot more? Is the curve going to keep going up steeply, or is it going to plateau a little bit?
I think if we look at the number of clinical studies ongoing, Don, we can only imagine that those clinical research studies will translate into new approvals. What I believe we will see is the proportion of precision medicine or combination regimens that are targeting particular subsets of patients will continue to grow, right? We've seen a few blockbusters in oncology, but more and more we see that the answer is better targets for patients that we know will predict good outcomes.
Well said. Okay. Daniel, can you move it forward one slide, please? So we talked about these themes, and the first one we're going to talk is about this digital revolution, right? It's in cancer care, probably all of healthcare, really. I'd like the panel to discuss this revolution. Okay, so we're seeing, a fair amount of abstracts presented here at ASCO. There's a sea change going on in the way patients are treated due to these digital tools. And Dr. Pat, we referenced you earlier. We know that this is important to you. If you look at this slide, we see, particular areas, EPROs and remote monitoring. We see telemedicine, telehealth. Can you please try to encapsulate, if you would, what these abstracts, this change that's going on, what these abstracts mean, and how it's changing what you do on a daily basis?
Of course, Don. So I think before we talk about the solution and how these abstracts contribute to that, I think we have to look at the problem. And while clinical informatics solutions improving on care delivery has always been of great interest, I think you never saw it greater than in this last year, where we saw many patients have higher barriers to appropriate care. You saw it in many different publications on how the COVID pandemic influenced patients' likelihood to screen for occult cancers. We understand that over the last year and a half, cancer screening has been down substantially, and likely the natural consequence of those delays in care will be a stage migration to more advanced cancers and more higher patient mortality in the many years to come. We anticipate this. We observed, in addition to decreases in screening, differences in patients getting the appropriate care that they need, a decrease in regular office visits, a decrease in therapeutic interventions. And so for the first time, clinical informatics solutions, digital healthcare solutions were one way we could reduce the barriers that patients have in receiving the care that they need. And so the telehealth, as people said, was the silver lining of the pandemic. And I'm excited to see that at ASCO this year, they're highlighting abstracts that are really building on that, really thinking about how you solve for problems in care. And I'll say, being a telehealth champion for many years before the pandemic, I was really happy to see it grow, really happy to see how it served patients. And in my opinion, it offers many ways to bridge these gaps in care. Because when I see a patient on telemedicine today, as I did 2 this morning before our call, they called me from their office. And so we interacted with them from their office, which means they didn't have to leave their place of work. They didn't have to travel over to my office to receive the care, to have appropriate medication monitoring. And so I think that these really represent changes that we're seeing today and have never been more important. So as we think about that, I think these posters really address that. The first poster, 1582, which is in the poster session, a group from University of Minnesota characterizes about 42,000 telehealth visits and characterizes how individuals interact with those visits. I will say one of their conclusions is that telehealth actually causes additional disparities in care. And I would say that we have to look at that a little bit more carefully, because I think that we learn different things. What they showed us is that utilization was different, video versus phone only, among ethnic minorities and older patients. And I will say that because of broadband access and proficiency with technical interaction, it may be that telephone only video conference, telephone only telemedicine visits are just more important for that patient population. So I think that this remains to be seen, but really happy to see that tremendous experience with telemedicine characterized and those researchers evaluating that important question. Building on telemedicine, we published an abstract in a manuscript on electronic patient-reported outcomes. This was based on the EORTC CTCAE criteria for patients to use a handheld application to try to characterize their symptoms at home that then interact with a nursing triage system. So we demonstrated that using the system, we onboarded almost 5,000 patients during the pandemic, and that this was a useful tool for patients. We could also use it to monitor oral medicine compliance, which has never been more important as we see the tremendous growth in oral oncolytics. And this was a collaboration between Texas Oncology and Navigating Cancer. We see that the NIH came forward and published information on cancer patients using remote cancer symptom monitoring during COVID-19 and showed that in the more than 200 patients that underwent symptom monitoring, that they had better symptom control with the use of symptom monitoring at home. So loved these builds on the digital health and how it translates to improved care and bridges that care that we have today. I will say too that imagine, if you will, some of the many challenges that have existed in telehealth for decades, that longitudinal care or cancer care is really the sweet spot for clinical informatics solutions, because patients have regular and consistent interactions with between doctor and patient. And so these are really timely. And then the last in these categories is the evaluation of increased intensity of PSA screening in younger African-American men with improved prostate cancer outcomes. So this looks at an important oral abstract session, really dealing with disparities. As you know, these men may not be eligible even to screen until 40, but what the conclusion of this abstract was that when men that are younger and African-American undergo increased screening, we know that they present with a lower stage. So there's a 40% reduced risk of metastatic cancer in comparison to patients that have a less aggressive screening strategy, and also an improvement in mortality. So I think that these are ways, in my mind, that we can bridge some of the gaps that exist in care today, and that digital healthcare is this silver lining, and we need to continue to look at how we bridge gaps and disparity that we see today in care.
Lee, what do you think? Is the digital revolution in cancer care just a fad brought on by a pandemic and about to go away? Or actually, could you maybe perhaps share, do you have an example of, practicing oncologists and how these tools have been helping patient care?
I think a couple of points to add to Dr. Pat's excellent discussion. So it's here to stay for sure. Accelerated, it's been around, as Deborah said, for a long time, but we did need reimbursement changes to make it happen, as is frequently the case for getting technology to be used in a more uniform fashion. I think, as everyone knows, the theme of ASCO this year is about reducing disparity and promoting equity. And if you look at this in the broad sense, we're moving from precision medicine that is focused on looking at the cancer and what the cancer is different. And we're also now looking at precision oncology from a social determinant of health perspective, which is equally, at least equally important, so that we understand there are different populations that have gaps that need to be filled in part by digital tools. And these are great examples at really just the very beginning of what we've been talking about for a long time, Don, which is patient-centered care. And there are so many elements to that, and so many dimensions, but digital tools can go a long way in reducing those disparities and really focusing on a true patient-centered experience by meeting the patient where they are.
Yeah, exactly. Okay, good. So I'm going to get us transitioning over to sort of the more, the clinical studies and the more clinical discussion. Before I do that, I want to remind everybody, yes, you can get the slides. Yes, the recording will be available immediately following. Put your name and email address into the Q&A box, and there will also be another opportunity to get the slides if you participate in the survey at the end. And with that, I think we're ready to move over. So Daniel, I'm going to ask you to move on to the next slide. We got about 30 minutes left, and we've got two buckets and a lot of studies within those themes, if you will. The first theme is movement into earlier lines with potential for cure. And, I would imagine as a medical oncologist here on the panel, hearing the word cure and moving these advancements up in the lines of therapy, it really is exciting. And so looking forward, we have 4 studies we're going to cover. And I think, Lee, we've asked you to cover the non-small cell lung cancer studies. Daniel, could you move on to the next slide, please? Okay. Lee, you ready?
Yeah. So the first study we're going to talk about is Empower 10 or 010. And to set the stage here, we know that patients with early stage non-small cell lung cancer really do not have a very good prognosis. If you look at patients with stage 2 and 3, over 50% of them will recur and develop advanced disease. And so it's very different than the circumstance, for example, in breast cancer, where the majority of those patients, even with up to stage 3 disease, will still enjoy a long disease-free interval. So we desperately need adjuvant therapy for non-small cell lung cancer in early stage. And as the audience well knows, chemotherapy by itself is modest in terms of its benefit. It does have a small and statistically significant incremental benefit, but we need better strategies here for sure. So of course, the biggest challenge, the biggest development, I should say, in lung cancer over the last 5 or 6 years has been the development of checkmate inhibitors. And as we normally do in our paradigms, which may be changing, but at least in this case is true, when drugs show benefit in the advanced disease, we move them into the adjuvant setting. And that's what was done here with Empower 010. And these were a large group of patients who received standard cisplatin-based chemotherapy with a doublet pair, and they could use a number of different drugs that are all used. So pragmatic approach to this. And these 1,000+ patients were randomized after surgical resection of stage 1B to 3A. And I should note that about 2/3 of the patients in this study were actually stage 3A, or those at greatest risk for recurrence. And they were then randomized after chemotherapy to atezolizumab, PD-L1 inhibitor, and they received 16 cycles or the standard of care after chemotherapy, which is best supportive care. And the median follow-up for this population is 32 months. And the data showed was a significant disease-free survival benefit versus best supportive care in both the PD-L1 selected population that was positive, and this was done by SP263 testing on tumor cells greater than or equal to 1% was considered positive. And then this was a hierarchical approach to statistical significance, and then all randomized stage 2 and 3A populations, and then also looked at the ITT population. So statistically, there was a benefit both in the PD-L1 positive patients and in all stage 2 and 3A populations, not yet seen for the intent to treat population. The hazard ratio for the PD-L1 positive population was 0.66, so a 34% improvement in disease-free survival at about 3 years of follow-up here for this population, and also an improved hazard ratio of 0.79 for the whole 2 and 3A population, and not statistically significant yet for the overall survival. Now, when you're thinking about adjuvant therapy, obviously the adverse events are much more important, because there are a number of patients here who would never have relapsed, and giving them any toxicity, particularly long-term toxicity, can be a concern. So here we saw more any grade adverse events with atezo compared to best supportive care. The grade 3-4 adverse events are 22% versus 11%, so about a doubling of grade 3-4. It'll be very interesting to see as we review this presentation exactly what those events were and how limited they were. So ongoing adverse events, especially immune-related adverse events, could be a concern. But again, this is a very different population than those who are going to, most of them are going to live without disease. Most of these patients would relapse. So we're willing to accept potentially more adverse events to get a very significant improvement and a clinically significant improvement in DFS. The one other thing I would say about these studies is some purists asked for overall survival before adopting this kind of strategy. We saw that in the adjuvant treatment of VEGFR patients. But I think it's fair to say in lung cancer, at least my editorializing here, is this magnitude of DFS benefit is likely to be clinically meaningful, and most patients would select to have this if it was approved.
Thanks for framing it like that, Lee. And I think you kind of addressed it, but I'll ask it. Last year, ADORA was all the talk, right?
Right. How
do you contrast those two studies?
Well, one thing that we didn't mention here, these were patients without known EGFR or ALK mutations. One of the things that I'll be interested in seeing at the presentation is whether all patients were tested for it. I would suspect many of them were not. So there may be a little contamination here just from the clinical trial perspective. But I think these data, while certainly not as impressive as we saw in ADORA, they're still impressive enough for this group of patients in the stage 2 and 3A patients. And this is showing a very strong benefit for immunotherapy, specifically atezolizumab here. So I would think that, I'm not a regulator, but I would think that these data would be fairly compelling if they hold up.
Sorry, I was on mute. There's a question out there. Why would we be more excited about Empower 010 versus the more significant advances in the ADORA trial? So I think, getting into the hazard ratio and the selection of patients, I think you addressed that, right?
Yeah, I mean, this is a very different population, and this represents the large majority of patients with non-small cell lung cancer. So.
Right. Okay. Daniel, can you move it forward, please? We've got adjuvant, and now we've got neoadjuvant non-small cell lung cancer. Take us away, Lee.
Okay, so Checkmate 816 was a study of nivolumab plus platinum doublet chemotherapy versus chemotherapy alone as neoadjuvant treatment for patients with resectable non-small cell lung cancer. Now, keep in mind that neoadjuvant therapy for these patients with earliest stage disease tend to be inconsistently used, and it's not a standard of care necessarily. And the reason it's not a standard of care is because it hasn't been clear that, and the studies have not been done to show that with platinum-based doublets alone, there's enough of a benefit, either in terms of pathologic complete response rate or in prolonging event-free survival, that this has become the standard of care. In selected patients, it's a very good strategy and particularly it tends to be a strategy used in the more locally advanced patients, those with 2B and especially 3A patients, or even those that would be borderline resectable, which were not included in this patient population. So in this patient population, we're looking at stage 1B to 3A resectable non-small cell lung cancer. They got platinum doublet therapy, as we heard, 3 cycles here with or without Nivo. And they had to have their surgery performed within 6 weeks. The primary endpoint was pathologic complete response. So one of the things that is interesting about this study is, unless I read it a few times, but I didn't see the PCR rate actually reported in the abstract, which was unusual, I thought, since that was the primary endpoint. In any event, the definitive surgery rate was higher with Nivo and chemo, 83 versus 75%. So was the minimally invasive surgery rate, which has a patient impact, 30 and 22%. Perhaps the most important data point in the abstract was the median residual viable tumor cells in the primary tumor bed, which were 10% if in the patients who got Nivo versus 74% in the patients who got chemotherapy alone. And so, as you can see, that number, I would say for the chemo alone, is what's been seen in prior trials. 10% as the median leads me to extrapolate that there was a significant number of PCRs, but we don't know that number yet. In terms of the adverse events, actually in this case, just 3 cycles of nivolumab really did not have much impact on grade 3 and 4 adverse events. It was actually numerically a little lower compared to the chemo arm alone. And there was no increase in surgery-related events, which is very important. And so these patients would undergo surgery in any case, whether they got neoadjuvant treatment or not. So this is a first phase 3 study in which a checkpoint inhibitor combination has shown superior efficacy. And I would say it's more of a proof of principle rather than a practice changer right now for a couple of reasons. First of all, in non-small cell lung cancer, as opposed to, again, breast cancer as the comparator, we don't know the impact of PCR. We don't know of the linkage yet of PCR to event-free survival and whether it is a good surrogate endpoint. We don't know that in most part because very few patients get a PCR. We see a substantial number of PCR under this strategy. That paradigm could well change, but we'll need additional research to make sure that that's correct.
Yeah, I think both of these studies are really exciting, though. In contrast to what we see in breast cancer, we all appreciate that patients with lung cancer have such tremendously high risk of morbidity and mortality because of their disease. And so I like the potential that these could potentially delay or deter advanced cancer, as that would be tremendously meaningful in this patient population.
Quick question from the audience about the AEs in this one. Was the dose typical dose for Nivo and the chemo?
Yeah, this was a fixed dose, but I mean, it's short treatment. I think that's perhaps the most important point here. This is only 3 cycles of therapy in combination with chemotherapy. Yeah. And whether or not, and again, the endpoint was a surgical endpoint. So whether or not we need to continue in the adjuvant setting and get further benefit in terms of particularly the event-free survival remains to be determined. But this again is a proof of principle looking at the biologic benefit of adding Nivo to killing cancer cells in the primary and regional nodes. Yeah.
Lee, maybe you could make a comment in the chat box just about what happens when a patient progresses here, relapses. You know, what are therapeutic choices? Because I want to keep us moving here. Dr. Pat, Daniel, could you move the slides, please? Next slide. We assigned you a couple of studies, Deborah, one in breast, one in RCC. I mean, really cool that we're talking about 3 different tumor types here in this setting. So could you please guide us through Olympia and Keynote 564?
Sure, Don, thanks. So in contrast to lung cancer, I would say that in breast cancer, we're really trying to figure out how to right-size treatment, recognizing that so many patients are cured of their disease. how do we think about increasing treatment for just the patients who need it? And you've seen that in recurring themes as we look at breast cancer through the Catherine study to try to offer adotrastuzumab to patients with HER2-positive disease that fail to respond clinically. And in contrast to the APT trial that offers a great long-term outcome in patients that we perceive to be low risk. How do we look at patients who need more and who don't? And so this has been where breast cancer is today, is most patients are cured surgically and some patients maintain a risk over a long period of time. Now, we've known in the last few years that not only does BRCA contribute to the likelihood of new cancer diagnoses, but also offers a potential therapeutic mechanism for patients with advanced cancer. And we've seen that based on the approvals of both olaparib and talazoparib in metastatic cancer, and in the trials that we've done to look at the neoadjuvant treatment of patients. And we know that those have been good. So is there an opportunity here to reduce risk in the adjuvant setting? And that's really the crux of what the Olympia trial addresses. And this is a late-breaking abstract, so we don't have data yet. But essentially, if you look at high-risk breast cancer patients that have germline BRCA mutations, is there an opportunity to reduce their risk? And so this trial accrued both, it's a phase 3 trial. It looked at treatment of olaparib in the adjuvant setting, 300 milligrams twice a day. It took both triple negative patients and ER positive HER2 negative patients. So all the patients were HER2 negative. Among the triple negative patients, which obviously have a higher risk of recurrence, it took any T2 or N1 patients that had received adjuvant or neoadjuvant treatment. And among patients with ER positive HER2 negative disease, patients that were 4 or more lymph nodes positive. So a high risk patient population to try to seek to understand if the use of olaparib 300 milligrams twice a day for 12 months would in fact reduce invasive disease-free survival. And the Safety Data Monitoring Board reported in February that this met its superiority endpoint, that in fact the use of olaparib 300 milligrams twice a day for a year among this selected patient population of somatic BRCA carriers that have higher risk disease, that it in fact did, it was superior at reducing the likelihood of relapse. So we're excited to see those results. Of course, we don't have them today. And as we look to say, gosh, if this is right sized, that it can reduce risk among this patient population, is this therapy going to be well tolerated? And thankfully, we have good data in the metastatic setting and in patients with ovarian cancer to help us answer that question. And we have, for those of us breast medical oncologists, we have good experience with this drug already. So very excited about that. And really it's the first PARP inhibitor to demonstrate clinical benefit in the adjuvant setting in a large phase 3 trial. So we're very excited about the Olympia trial. Moving on to how we continue to improve upon adjuvant outcomes, you can look at our high-risk patients with renal cell carcinoma or kidney cancer. And I will say that many patients with kidney cancer do have high risk of recurrence to metastatic disease, but particularly those with grade 4 cancers or sarcomatoid kidney cancers, or T3 cancers, or T4 cancers, or node positive cancers. And so the Keynote 564 trial really asked the question, is if patients with renal cell cancer that have a high risk of recurrence, if you administer pembrolizumab every 3 weeks for up to 17 doses, could you reduce the risk of recurrence and improve the outcome in this patient population? And I will say, again, this is a late-breaking abstract that has not yet been released, so we don't have all of the data on this, but I think that this is something really to be watched in close and have close interest, because supposedly this did meet its endpoint and is a positive trial. So while we've seen many drugs in kidney cancer have positive outcomes in the metastatic setting, I will say some of the adjuvant trials have been disappointing. And so it is very exciting to see this phase 3 trial utilizing pembrolizumab as a positive trial that will be reported. So I think that we will all watch this plenary with interest, as I think it's likely to be practice changing.
Thanks, Deborah. Did you you see this question here about commenting on the BRCA testing for all breast cancer
yes.
patients?
So what does Olympia bring to us? I think that it opens our minds as to how we think about genetic testing in patients in the adjuvant setting. And I will say I've seen genetic testing in my 15 years in practice change tremendously. Initially, when we had guidelines, it was to test women that were under 40, and we didn't routinely test metastatic patients. Now we routinely test patients that are under 50 and have a lot of key indicators or specific types of cancer, like triple negative cancer. But really, all patients now that have metastatic breast cancer should be treated. What this would tell you is all patients that meet these inclusion criteria, that either have triple negative cancers that are T2 and 1 or 4 or more lymph nodes positive and ER positive cancers, really should all be getting BRCA testing. And so what I think this does is it makes us as oncologists rethink our indications for doing genetic testing in this patient population.
Yep. Okay, so we're going to transition on, but I'll wrap that up by saying, moving these great therapeutics that are demonstrating efficacy in metastatic setting and moving them up with the intent to cure. Wow, right? Really cool ASCO this year. I just feel like so many times people say, oh, it was a dud of an ASCO, and it never really is. Okay, Daniel, if you could move us forward, please.
Don, one last comment on that category. I think what's notable is to understand that we started with a discussion about the rapid pace of innovation with immunotherapy and checkpoint inhibitors, as well as the rise of targeted medication, more ability to select and identify and treat the right patient. And we're seeing that in the curative setting with both of these modalities.
Yeah, great point, Sharon. So now we're going to innovate on past successes. We have about 15 minutes left in the session here. So, we'll try to move them pretty quickly. Daniel, I think if you could move forward one more, please. I think we have Lee coming in to talk about this first one. This is a novel anti-LAG3 in melanoma. And Lee, if you could please summarize this study.
Sure. So we have a number of immune checkpoint inhibitors, but we're still looking for the killer app, if you will, the combination with the PD-1s or the PD-L1s that will move the field further. And this is very interesting, the relativity 047 done in patients with melanoma, where we've arguably seen the most success for these drugs. LAG3 inhibits T cell activity, and the goal here using an antibody against LAG3 is to restore effector function for exhausted T cells, which we know is one of the mechanisms of immune escape in patients who receive checkpoint inhibitors. So these patients were untreated melanoma. They were treated with either Nivo every 4 weeks or alone, or added this drug, relatlimab, that is the anti-LAG3, and still fairly quick follow-up. The median progression-free survival was more than doubled with Rela plus Nivo to 10.1 months, and the progression-free survival 1 year was 47.8 months versus 36%. There was some more grade 3-4 adverse events as expected in the combination therapy, and more discontinuation. I think this is really strong data in this population that is showing that we have a meaningful combination now. And this might be a better combination, can't tell from this study, but Ipi-Nivo, which has also been used in melanoma. So very exciting. And I think it is proof of principle that LAG3 is an important target for as a checkpoint for a checkpoint inhibitor monoclonal antibody, as shown here.
Yeah. Okay. Sharon, do you have any comments on this one about, replacing one for another, substituting one for another?
I think what's wonderful about our field is that physicians, scientists, researchers, we're always looking to improve outcomes for patients. And even with strong survival rates that we've seen with the Ipi-Nivo combination for newly diagnosed melanoma patients, if there's an opportunity to reduce the toxicity of that very strong combination regimen, then we can deliver great efficacy while improving the outcomes for patients and reducing the burden on them. So it's wonderful to see that in this case, the sponsor is looking to even outcompete itself in terms of a better modality for patients.
Right, right. All for the good of the field. Deborah, you're up next. We're gonna, and Daniela, could you please advance the slide to the prostate cancer study, another LBA? And there was some discussion amongst us as to whether we should include this one, and Dr. Pat and Dr. Schwartzberg were emphatic that this is a very important study, and so we should include it in the presentation. So Deborah, if you could please.
Sure. Well, Don, I'll say prostate cancer has really had a tremendous number of successes in the last 15 years that have been so meaningful and that have improved overall survival in patients with metastatic castrate-resistant prostate cancer. I think it's tremendously important. And so as we look at that, obviously docetaxel and androgen blockade with abiraterone, enzalutamide, and apalutamide have been tremendously powerful. So this would add really to that armamentarium, especially if it shows an overall survival benefit, which is reportedly the positive endpoint that will be presented in this late-breaking abstract. So the VISION trial is the phase 3 study of lutetium-177 in patients with metastatic castration-resistant prostate cancer. So it looked at patients who had been previously treated with docetaxel and androgen blockade and offered them this radiopharmaceutical administered intravenously every 6 weeks. And among this patient population, reportedly, there is an overall survival benefit and a benefit in response on scans. So, nobody talks a lot about prostate cancer. We talk a lot about other cancers. We talk a lot about breast cancer. I'm grateful for that. But really, we've had these tremendous successes in prostate cancer that have contributed in many years to overall survival advantages among this patient population that remains at tremendously high risk. So we are excited about this. I will say that radiopharmaceuticals is a really interesting area, both because when they demonstrate efficacy, the logistics of administration and a reimbursement hazard in this targeted type of therapeutic intervention remains a little more complicated than other therapeutic interventions. So there are operational and reimbursement concerns that will likely influence its utilization in patients with advanced prostate cancer. But I think this is tremendously exciting and likely practice changing.
Great. And Lee, you were also sort of strong on this one. Your thoughts real quick?
Yeah, I think this is the first time we've seen radioligand therapy applied to a very broad population. And this is a population that really doesn't have many options because the patients in this trial had all had taxane therapy and all had at least one novel anti-androgen. So kind of at the point where there isn't necessarily anything good, which is why I was against best supportive care. So I do think these are getting easier. It's a new technology, as you mentioned. This particular agent, I believe, has less toxicity and perhaps PrEP associated with it than some of the previous lutetium agents that have been used in neuroendocrine tumors, a small population. Here, we're going to see, as Deborah said, a much larger population of patients who might benefit, and that will drive innovation in access and utilization.
See, Sharon, I told you radiopharmaceuticals have a future. Inside joke. So Daniel, if you could please move it forward one more here. And what we did with this one, Sharon's going to summarize these 3 studies for us. Felt like it was, rather than go through them individually, put them here on one slide for your viewing and summarize them as CAR-Ts are really making some noise as they continue to evolve and develop in oncology. So Sharon, if you could please.
Certainly, Don. It feels like ASCO would be incomplete if we didn't acknowledge the innovation in cell and gene therapy. And while we are seeing new data at ASCO there this year, focusing on some of the phase 3 studies with existing agents, what we wanted to highlight today is really the way that the pharmaceutical industry and research is continuing to look at ways of making cell therapy better and broadening potential use. So why have we selected these 3 studies? The Spearhead-1 study is a phase 2 trial This is a T-cell receptor mediated technology. What's exciting about afem-lutol is that this is really one of the first studies where we've seen in a population that's showing efficacy and tolerability of a T-cell based therapy in solid tumors, right? Most of the innovation we've seen and the very strong outcomes we've seen, for example, of the CAR Ts, have been in hematological malignancies, DLBCL, marginal zone lymphoma, ALL. So the nut to crack here is really, can we see a benefit in solid tumors? And indeed, in the synovial sarcoma population, which formed the majority of this approximately 30 patient clinical trial, we saw both promising efficacy in terms of some complete response and partial responses, and overall response rate across the 23 or so evaluable patients, but also a reduced toxicity profile in terms of things like cytokine release syndrome. So the option to be able to take these T-cell mediated treatments into the solid tumor area is certainly an area of very active and strong interest across the research landscape in oncology. The second innovation I want to point to is the ALPHA2 study in 2529. This is looking at a combination of a monoclonal antibody, ALLO-647, and ALLO-501A, which is an allogeneic or off-the-shelf CAR T-cell approach. Now, anyone who's familiar with this field knows that for all of the very exciting efficacy that we see with CAR Ts, the dominant treatment today, autologous CAR Ts, require a significant amount of preparation time, cycle time to prepare these individualized therapies for patients. So the ability to bring a efficacious, tolerable, off-the-shelf CAR T that could be produced locally at the site of care has tremendous potential to, as Dr. Schwartzberg just mentioned, improve the access and potentially help improve the cost efficacy for these therapies. So this ALLO-501A treatment from Adaptimmune Therapeutic, or from Allogene, will be the basis for an FDA Fast Track designation for further development in relapsed refractory DLBCL. And certainly this study and the modality that I know many in our industry are watching closely, the CARTITUDE-2 trial. This is a phase 2 trial of a BCMA targeted CAR T from Janssen. And what's interesting here, if we think about the area of BCMA targeting in multiple myeloma, this is a field that has also exploded in recent years. We've seen availability and FDA approval last year of an antibody drug conjugate targeting BCMA. We saw in March the approval of the first CAR T targeting BCMA from Bluebird Bio and BMS. What's interesting here about this is it's an infusion in patients who've had as early as only one prior line of therapy. These are patients who've refractory to IMiD, refractory to have been treated with dexamethasone. They've also received proteasome inhibition. And the exciting potential here is moving CAR Ts into earlier lines of therapy. Many of the currently available CAR Ts have been approved for patients that have previously failed 3 and sometimes even 4 lines of therapy. So the ability to use an autologous CAR T in patients who've had 1 or even 2 prior lines of therapy and demonstrate a benefit and potentially a curative efficacy is very, very exciting. So as we've seen throughout this ASCO preview, we see that sponsors, researchers, clinicians are willing to take risks and try new things, innovating in a mechanism which is very, very promising, right? Cellular therapy in oncology, and expand that to solid tumors, to earlier lines of treatment, and potentially even revolutionizing the availability of CAR Ts through off-the-shelf technologies.
Yeah.
Lot to cover, but very exciting developments.
Great summary, Sharon. Appreciate it. We're going to do a poll, and we're not going to do it yet, but we are going to do a poll, and I'm going to ask the panelists to comment on the poll results. So please hang in there for a little bit longer. We've also got a couple questions I want to ask. You know, it seems like the theme around that vision study, the prostate cancer study, is, you know, the logistics. And you both sort of addressed it, but I thought one of the interesting questions was, you know, okay, so you have a hurdle with the logistics of a radiopharmaceutical, but at the same time, you have, you know, some pretty compelling clinical data. Is there, you know, and we don't know what the final data is going to be, as you know, can you put your finger on a magnitude of benefit that at that point it becomes, okay, we need to do this. And Dr. Pat, Dr. Schwartzberg, any thoughts on that?
Well, I'll just say, I think that you've seen tremendous benefits from docetaxel and from androgen blockade in this patient population that have led to really clinically meaningful overall survival benefit. So I think if there's clinically meaningful overall survival benefit, it's hard not to do it. And actually, I think that while radiopharmaceuticals are a challenge, and it's not from administration, because you can administer them in any office room, but in terms of the supply chain of managing the pharmaceutical requires special handling and storage because it's radio labeled. And then reimbursement has been a hazard. But I would say that I think that if it is indicated for this broad of a patient population, it's powerful enough to influence things like payment coverage policies, and for people to address the supply chain issues and storage and handling challenges that are introduced, because it will be so important.
Lee, any thoughts?
No, I agree. I think Deborah summarized it very well. I do think that most community practices larger community practices could adopt this over time.
Yeah, yeah. Daniel, can you move forward, please? So we're going to run a poll now. Please hang in there for a couple more minutes. We'll run the poll and see what the results are, and maybe we'll get some comments from our panel about it. And in the meantime, while you're answering the questions, you can say which of the 3 themes that were discussed today are you most excited. Remember, we had the digital health revolution, moving into earlier lines of therapy. And then at the end here, we had innovation on past successes, including the 3 CAR Ts as well. So we'll see some poll results, and then we'll ask them to comment on them. And I'll remind you that you can put your information into the Q&A box, and we'll be able to get your the slides out. And we'll get you the slides, but there's also going to be a recording hosted. I don't know exactly when. Sharon, do you know when that recording is going to go up?
We'll have it within a few days, Don.
Yeah, okay. Daniel, can we see the poll results? It's a landslide. Okay, so we've got the results here.
Maybe I could just comment. I think what Dr. Schwartzberg and Dr. Pat highlighted in our earlier discussion is that we've seen tremendous success in the adjuvant and neoadjuvant settings for a disease state like breast cancer. We can stratify patients by risk. We can understand some of the biochemical and now genetic markers that predict that risk. And we've seen the efficacy of novel endpoints like pathological complete response translate into meaningful long-term disease-free survival. The potential to see it in fields like lung cancer and kidney cancer, which historically have not had very good outcomes when we've tried to move treatments into those earlier settings. I think what we're seeing is a sea change, and there's a lot of excitement around that.
Amongst physicians and amongst our audience, I guess, right?
Well said, Karen.
Yeah. Any surprises here, Dr. Pat, Dr. Schwartzberg? Too bad the digital health didn't do as well as we hoped.
No, I mean, I think that, we're always, ASCO every year, everyone is always looking at how to think about new and novel therapies and how they can, continue to move the mark. It's been a remarkable time of innovation in cancer care in the last 15 years, as we started this session saying. And so I think everyone's excited about what more we can do. I can remember 20 years ago going and hearing the director of the NCI saying that cancer would be cured in 20 years, and here we are. And I would say that my goal is different. I see us really moving cancer to a more chronic disease and to increasing number of cure rates, but where we can't, moving it to chronic disease. And I think that all of these things help us get there faster, whether it's delaying or deterring metastasis or giving targeted right-sized therapy to patients with more advanced cancer. I think that every year ASCO gets us closer.
And I would just add, I think the audience's enthusiasm for adjuvant therapy and cure is really based on the fact that that's where we're going to make the most impact, is detecting cancer earlier, screening cancer better, and treating earlier stage disease before cancer has a chance to genomically diversify and make it more difficult. And so I think moving these up into the early stages of cancer is going to increase our cure rate. More cancer survivors who will need more digital health going forward and other success. But the first step is to increase the cure rate.
You know, I'm going to come back to you in a minute, Sharon, but, you know, just real quick question that I'm looking at that got me was, you know, is it, you know, there's less biomarker testing for early stage non-small cell lung cancer in the community versus academic? Does that sound like a fair statement? And if that's the case, you know, what does this study really mean? I mean, we're talking about cure and so forth, but, you know, is that a real hurdle for community oncology, and can it be addressed?
What do you mean is what a real hurdle?
This less testing for biomarkers in non-small cell lung cancer in the community setting.
Well, I think that we are not moving towards an era of less testing, because I think that we've learned over time, especially over the last 5 years, that there's been tremendous advancement in the molecular understanding of how to treat, especially patients with lung cancer. What I would say, though, is that I think barriers to testing historically have been the cost of testing. And getting additional biopsies for testing, and with the ability to use cell-free DNA and disruption of costs, bringing the cost down, and the rise of therapeutic interventions that are so effective, that dynamic is changing. And so less testing is not the goal that we're striving for. We're striving for long-term disease control. Cures when we can have it, and great, but when we can't, long-term disease control, treating patients chronically with minimal symptoms so they can live their life in their home with their families.
Dr. Pat, I just wanted to say, I'm so glad you brought that up, because I do think it's not just about earlier testing, but it's also about equity of access to testing. And we know, for example, as we saw in the screening data, that underrepresented populations historically may not receive the same rates of genetic and genomic testing. Their data may not be represented in algorithms that we develop around treatment modalities. And so the importance is not just earlier testing, but I would argue also broad education and representation of diverse patient populations in those early testing pools, so that data is reflected in our treatment algorithms and guidelines.
Yeah, I'm passionate about this because of the focus on precision medicine, and what I see is a whole different topic, but as potentially increasing inequities in precision medicine because of the complexity, the ability, the need for even greater health literacy, both among physicians and patients, to understand the volume of data that we get from a comprehensive genomic profile. And I really urge industry to rise to this challenge and help us solve this issue.
Yeah, and I think you can actually look at this meeting. I know Nick Robert has an oral session on the MyLung data, which is a real world data, a biopsy of patients in many of the US oncology practices to look at their distribution of genetic profiling in lung cancer patients and how that translates into therapy. So I think this is a space where looking historically at what we've done and moving forward to think about how we can sort of nudge and facilitate the right practices moving forward is critical.
And I'll do one more. Okay. So I know we're out of time, but, you know, I thought it was interesting. Somebody brought in a question about the digital tools that we talked about. And I guess, you know, really we're talking about patients that are getting cancer care, but what about the impact on survivorship? Do either of you have any thoughts about that?
Well, I think that survivorship has to grow. You know, it was progress 10 years ago to do a survivorship care plan and document, but many of our patients are living with chronic cancer. And so, but they anchor their belief about cancer to this terminal illness. And so it brings up a whole new issue, especially among patients with advanced cancer who are living with this as a chronic disease, who likely will continue to work, continue to make dinner for their families, continue to pick up their kids from soccer, sleep in bed with their spouses, and feel well. How we support them differently. So I think that our addressing survivorship and symptom management more broadly as patients survive through their cancers and hopefully thrive is just continuing to grow like therapeutic intervention in cancer.
I'd like to see, in addition to that, I'd like to see a renewed focus on interoperability. I think one of the concerns about survivors, particularly those who don't have active cancer, so looking at that population, other than the one Deborah just talked about, where we certainly use these tools, is the information is hard to transfer from the oncologist to the primary care physician. We know there are not going to be enough oncologists to maintain all of the long-term survivorship needs that we have, as the demographics, suggest that we'll have more patients over the next 15 years. We're not going to be able to handle that. So we need ways of using digital tools among professionals so that the information can be disseminated more broadly, and that we can develop a different group of individuals perhaps to have those digital tools and the information to take care of those who have had cancer and are still coping with some of the toxicities or potential long-term side effects, but are not active.
Yeah. Cool
This conversation reminds me of a remarkable ASCO session a few years ago. I believe it was a study out of Memorial Sloan Kettering that showed that patients, even using a web-based self-monitoring portal, had overall survival gains of something like 5 months across tumor types, which shows that not only is it better for physicians in terms of helping their patients, but it results in better outcomes for patients. So my hope is that with the advent of more telehealth, the adoption of those self-monitoring patients will become something that's a survival benefit accessible to many, many, and in that long-term survivorship mode.
And Sharon, I would say in that vein, that was Ethan Bosch in 2017 that presented the EPRO data out of Memorial. And so that was using the CTC, PRO CTCAE framework that is the basis for the health tracker application that we're presenting this year. And I think that especially in this year, it's really called our attention to where these kinds of ways that you can bridge gaps in cancer care really can bring patients closer to their physicians and their clinics virtually, and have opportunities for better symptom control. It can influence drug adherence, it can influence time on therapy and patient overall survival, patient satisfaction. So I think those recurring themes are really important. We need to build on them. Now is the time.
What did I say? History repeats itself. Here we are, we're way over. We learned about the pace of change in oncology. We learned about clinical studies impacting the digital revolution. We learned about moving therapies up in earlier stage. And we learned about innovation on top of therapies that have already established themselves a bit. And then we had a great discussion, and we learned about precision medicine too. We had a great discussion, great audience participation. We have a lot of requests for slides in the Q&A. One last chance to throw that in there. But great comments and questions from the field, and Sharon and the team at ZS, awesome work getting all the content together for us, getting us organized and allowing the big audience to participate in this thing. So thanks to ZS and Associates for their help today too. And to Lee and Deborah, sorry we kept you on a little bit later, and on to the next thing, but thanks very much for your time.
Thank you.
Thank you.
Thanks everyone.
Great discussion again.
All right, take care.
Bye.